Dr. Jody Russon. I'm from Drexel University, which is here in Philadelphia. I'm from the College of Nursing and Health Professions, specifically the Family Therapy Department, and I work out of the Center for Family Intervention Science. I work specifically with depressed and suicidal adolescents from an approach called attachment-based family therapy, which I'm going to be speaking with you about today. But I want to get a sense from you all. How many of you work with adolescents and their families in your practice? Okay, so a couple of you. How many of you work with suicide specifically? Okay. All right. Well, I want to pick up the conversation that we were starting to have with the bullying and a little bit about the military, which we just heard, and about migraines as well, is that suicide is a huge problem impacting our youth, and therefore more evidence-based work is needed. And I'm going to just give you an overview of attachment-based family therapy, tell you about the empirical support that we have backing up the model, and then giving you the clinical tenets of how we operate. So just a little bit about this model. Gary Diamond, not related, Suzanne Levy have developed this model, and we operate out of the Center for Family Intervention Science, provide trainings, do research to find better ways to engage family around these critical issues involving adolescents and young adults. If you want to learn more about us, we're on Twitter, Facebook, we have a website, so check us out if you're interested. So as we all know, adolescent depression and suicide is a huge problem. 11% of adolescents have a depressive disorder by the age of 18. And then, a lot of the medical staff we work with are so surprised to hear that suicide is the second leading cause of death for young people ages 15 to 24 years of age. So it's a critical issue amongst adolescents and young adults. And then out of the people who are contemplating suicide, who are thinking about it, there are approximately 2 million who attempt suicide each year. And that includes both attempts that go through and attempts that don't go through, that are not successful. So attachment-based family therapy has been studied as a 12 to 16-week treatment. It's been developed for depressed and suicidal adolescents. However, it has different capabilities to work with other youth with other disorders, particularly internalizing disorders such as eating disorders and anxiety. It's built around 5 distinct treatment tasks, which are aimed at involving the family. And in our therapy, we really see parents as the medicine and not the problem. So we're engaging the parents in the treatment. We're empowering them to do something different with their kids. The manual is very goal-oriented, but it's flexible. It's not rigid. It will not tell you what to say in each place. It's really open to clinical judgment and interpretation, but we focus on a specific set of tasks and goals in making family change happen. It's based in attachment theory by Bowlby, which really emphasizes the secure base as the preferential development pattern for youth and adolescents, and there's even work to suggest that it's true in couples relationships as well. And then, of course, in structural family therapy, too, that's where we get our directiveness and intentionality in the family system. Our practice is on the National Registry of Evidence-Based Programs and Practices, NREP, and then it's also a proven practice on the Promising Practices Network. So I want to emphasize, too, that our model is not something that's brand new. It's what a lot of clinicians have been using for a long time. We stand on the shoulder of a bunch of different theories in family therapy, and we take the bits and pieces that seem to be most relevant for moving these kids from a depressive state to a more engaged state with their family. And so I probably don't have to go through all of these theories. You probably heard about them here and there, but we take parts of each one to construct this model. So ABFT has been shown to be effective with depressed and suicidal adolescents in 5 different studies in the past decade, and I'm going to go through our most recent published study from 2010, where we got funding from the CDC to test attachment-based family therapy versus treatment as usual out in the community. So I want to just explain what enhanced care as usual was. So the adolescents either got randomized to come to our center for treatment. We were at the Children's Hospital of Philadelphia at that time and received treatment with us, or we followed them and gave them assessments out in the community with community providers, community counselors, family therapists, psychologists, other people who could provide care. And this is just a little bit of our sample, primarily African American sample, primarily female. About half had attempts before. You can see here that we did get pretty significant findings in our study after the 9 months follow-up, and then also after post-treatment. The suicidal ideation dropped significantly. The blue line is ABFT. The red line is enhanced usual care. So it dropped immediately after treatment, and then at follow-up it continued to remain low. The SIQ suicidal ideation questionnaire is a self-report measure, and it's validated to determine the level of risk and a level of suicidal ideation for adolescents. So one of the really interesting things that this study found was that regardless of a history of trauma or sexual abuse, the kids in our ABFT condition continue to do well. In past suicide research, a lot of studies have found, CBT, interpersonal therapy, these studies work great, except when kids come in with a history of trauma and sexual abuse. And that just has a big impact on treatment outcomes. And so we were really excited to find in our study that no matter the history of trauma or sexual abuse, our kids were getting better as a result of ABFT. And if we think about ABFT, it's a trauma-focused model. It's brief, but it helps kids to be empowered to talk to their parents about their relational traumas. So we address some of those mechanisms in the work that we do. And I will say one more note about this study is we compared the average number of sessions attended between the enhanced treatment as usual and then the ABFT condition, and the ABFT conditions had a statistically significant number of more sessions. So the average number of sessions in the ABFT condition was 11, whereas the enhanced care was 3. So we had much greater treatment retention. We don't know if that's because they were coming to our center on our university versus out in the community and we could do more to engage them, or if that's actually a result of the therapy itself. And our next study will be able to answer the question for that. So just a little bit about the dissemination efforts. We've disseminated the model and taught the model to family therapists, individual therapists, nurses, psychologists, psychiatrists, lots of different professionals that work with families. We do it internationally and we do it in the United States as well. And right now, there's a really special project going on in Belgium where ABFT is being implemented center-wide. So the milieu therapists use it, the psychiatrist uses it, the recreational therapists use it, the nurses use it. And so that kind of global mentality of attachment-based family therapy is really serving to kind of join together the fragmented parts of theory that this center was using before. Okay, so just a quick note about some of our other research studies. They can be found on our website, but I just want to give a brief overview here. We do a lot of work with lesbian, gay, bisexual, transgender, and questioning youth. Unfortunately, we found because of parental rejection, low resources, homophobia out in the community, that these kids are really struggling in terms of depression and suicide. And so that's been a big mission of our center, to provide care for that group in particular. We've also done studies that look at ABFT as an aftercare treatment. When someone attempts and are hospitalized, then they send them to us and we take care of them and see how that goes. And it was shown to be effective as an aftercare treatment and providing adolescents with more structured support than just regular outpatient therapy. ABFT has also been used in adult populations as well, so young adults. You know, as therapists, we always think about the way that most of the time is talking about one's parents and disappointments there. And working with adults, you actually get a chance to bring in your parents and talk about that process, which is interesting. So it's been compared to emotion-focused therapy for young adults with unresolved anger, depression, and resentment towards their parents, and has been effective. Currently, we're just getting to the tail end of a 5-year randomized controlled trial testing attachment-based family therapy with non-directive supportive therapy. Stay tuned for the results. That's going to answer a lot of questions for us. Is the family therapy process making the change, or is it just the common factors of therapy that are promoting the change? And so we'll be able to have a lot more information after that is through with data collection. So I want to tell you a little bit about ABFT itself. Like I said, it's a set of principles, a set of goals that you do with the family. It's not rigid, it's very flexible. It's all about intentionality. So every intervention, every statement you're making to the family is moving you towards a purpose, towards a goal, towards making structural change happen. The self of the therapist remains central. We're working with a lot of emotions. We're talking with kids about the rejection from their parents, about their betrayals, hurts, traumas. And we're also supporting the parent at the same time to get them into an empowered place where they can take care of their child again. So in order to deal with those dynamics and emotions, the therapist has to be very grounded. So we do a lot of self of the therapist training. And it's not a curriculum, like I say, it's like a roadmap. You have an idea of what you want to do, but it's your way of negotiating and managing the family that can move you through those different goals. So we call ourselves client respectful and not necessarily client-centered. The traditional client-centered approach is very non-directive. The client leads the sessions. And we find that with suicidal youth, the families come to us needing care and expertise and a sense of what to do next. So we take a very directive approach with families. We really feel that we come in with the medicine, we have this practice, we can help you. This is a crisis situation, but we gotcha, and we're going to work with you. So it's very collaborative, but we also use ourselves as the expert in the room to guide the family, to negotiate with them, to make sure that the family structure is where we want it to be. We also use a huge breadth of literature on family psychology and family practice to inform our work. And we also go to Gottman's work and some of the other parenting literature on most effective parenting practices for caring for youth who are distressed. So we have 5 key treatment tasks in attachment-based family therapy. The first treatment task is the relational reframe. We get our kids referred to us from CHOP or Friends or other local hospitals in the area, and they're coming into us in crisis and panic. My kid just tried to take their life. I don't know what to do. So our first goal is understanding and assessing that depression, but then we're doing something very unique. We're shifting the frame to a relational theme as opposed to a framework of the depression, a framework of pathology. We're saying when you are so distressed, when you feel like hurting yourself, why can't you go to your mom for support? What's going on in this relationship where you can't use your mom in the way that you need her? And so the answer to that question is really the pinpoint that frames the rest of the therapy. In the next phases, in the adolescent alliance and in the parent alliance, we're meeting alone with the adolescent and we're meeting alone with the parent individually and preparing them to come back together and have a conversation about ruptures and about what has gotten in the way and why the parent can't be a resource to them in their depression. Now keep in mind, we are putting the depression conversation and suicide conversation on a hold while we do the relational work, but it's the goal of the therapist to monitor the depression until the family can effectively monitor it and manage it themselves. So we stand in Bowlby's words, as a secure base from which the parent can learn and operate until the family can grow. So coming back together in the repairing attachment, that's when we empower the kid to tell their parents what has gotten in the way of the relationship and how they haven't been supported in the way that they need. And then finally, in promoting autonomy, now that that secure base is reestablished, we work on other things that contribute to the depression: bullying, social isolation issues, self-esteem, sibling issues, worries about going to college, worries about getting through high school, whatever it may be. But we come from the stance that until the family dynamic is well supported again, the family can't move forward with these other more behavioral tasks. It's a fundamental process that has to happen first. So just a quick note about suicide management. We are always assessing suicide in the work that we do. We're giving out measures such as the Suicidal Ideation Questionnaire, Columbia Suicide Severity Rating Index, reasons for suicide. We have safety plans enacted, so we're really monitoring the suicide, but at the same time doing the family work. And then just a couple closing statements. I just encourage you to always have a model, always have a theory of why you do what you do, but then perform it with great artistry in a way that works with the family that you're treating. And also, please don't be afraid of suicide. You know, there's tons of studies that show when you ask about suicide, that doesn't cause somebody to hurt themselves or kill themselves. They'll just answer with how they feel. The family's already afraid of suicide too, so it's up to you to be that beacon of hope. And out of crisis, we find that great opportunities arise for families to rebuild love and connection in their relationships. So thank you. Does anybody have any questions? Yes?
Could you give an example of how you empowered the teen to rebuild and reconnect with the parent?
Yeah, that's a great question. So task 2 is a fundamental part of the therapy. The task 2 lasts about between 1 and 3 sessions. And what we do is we start by joining with the adolescent. We understand what their motivations are, what has made them depressed, what the context of their world looks like. We show them that we're a safe person to join with. Then we start talking to them about what we call their attachment narrative. So it's the schema of how they believe their relationship with their parent has impacted them and impacted their depression. And from attachment theory, we know that the caretaker's engagement really has a big impact on the adolescent, so we can help guide them in that. We do a lot of work then to help the adolescents see how these ruptures, how these pains, how when their caregiver wasn't there for them, how that gets in the way of them being able to have a more normative developmental experience and why they keep getting depressed again. Then we say, you know what? You've been dealing with this on your own for so long. You've been quiet about this for such a long time. I want to help you tell your mom this. I've been meeting with her. I know she wants to hear from you about this. And I say mom. We work with a lot of dads, sisters, grandparents, everyone. But we make sure that they're prepared. We go through them step by step of how they're going to tell their parent, and we do it together.
Like what would be one step?
Mm-hmm.
Like give an example of, you're going to say to your mother this, or
yeah.
That's what I'm wondering.
Yeah.
Give an example.
So it depends on what that adolescent's attachment narrative is. So we've had adolescents who have said, you know, when dad was abusing us, mom didn't throw him out of the house, and he was there and he was awful, and I can't forgive her for that. And preparing to tell mom that would look very different than every time I talk to my mom, she criticizes me and I feel like I can't trust her. So the first step is we understand what the narrative is. Then I talk to the adolescent collaboratively of how do you want to share that to your mom? What do you want to start with? Do you want to start with how you feel when that happens? Do you want to start with what happened? Do you want to start with, you know, how you wish things could be different with her? Where do you want to start? So the answer to your question is much more of a collaborative conversation. Yeah. Yes.
What if you have a patient with mental illness? How do you approach that? Because that's different if there are all these circumstances. But what about somebody who is depressed or have that suicidal ideation because of mental illness?
Right. So do you mean the patient or the parent?
No, the patient.
The patient, okay. Yeah, so the way we go in with it is we believe that depression and suicidal ideation can happen for all sorts of reasons. It could be biology, it could be family relationships, it could be bullying at school, but regardless of where it comes from, the parents are part of the solution. So oftentimes we see families where the actual illness causes the discrepancies and disruptions in the family. So we will get the family back in line with how to deal with that disorder effectively. Because right now it's probably all chaos and the kid's not being monitored or supported in the right way. So we go through the same process with them. We talk to them about what's getting in the way of their parenting. We help the kid come up with saying, you know, maybe I need more autonomy, or maybe I need more support, or maybe I need somebody who I can talk to at the end of the day about this. So it's the same process, but we just always have that perspective that parents are the medicine, and that if they're given the tools and empowered to address their kid differently, it's going to help across the board. And there may be a psychiatric referral in that case. We would help the parent find psychiatric services for their kid. We do a lot of resource coordination in our work. So, okay. Any other questions? All right, thank you very much.